Well, good morning, good afternoon, and good evening to all of our webinar participants around the world. We are thrilled to have nearly 300 individuals that have signed up to participate in this webinar focusing on impact bonds for health. My name is Emily Gustafson Wright. I'm a fellow in Global Economy and Development Program here at the Brookings Institution. We have been researching the global impact bond market for about 4 years and have published 5 reports and several other pieces on the topic to date. Sectorally, our focus has primarily been in the early childhood development sector, or programs that reach children from before birth to transition into primary school, including a range of education, social protection, and health interventions. We feel that there's a great deal of potential for impact bonds in the health space in both high-income and in developing countries, and it is a great pleasure to have such an excellent set of panelists and discussants on this topic today. As an overview of today's webinar, I'll start by giving a brief presentation, including a quick Impact Bonds 101 for those of you who are new to the topic, as well as an overview of the global impact bond market, and particularly those impact bonds in health. I'll then introduce our 3 esteemed panelists, each of whom will give a short presentation describing an impact bond for health in which they are participating. This will be followed by a moderated Q&A from the webinar audience. After this, we will have a presentation from Megan Golden of Mission Cure, who will be speaking about a new idea to use impact bonds to fund disease cure. We then have the distinct pleasure of being joined by Ambassador John Simon, currently the co-chair of the board of the Global Fund to fight AIDS, TB, and malaria, as well as founding partner of Total Impact Capital. He'll provide some comments on all 4 of the presentations. Finally, at the end of the webinar, there will be another opportunity for questions from the webinar audience. You can join the conversation on Twitter using the hashtag ImpactBonds. Our Twitter handles can be seen on your screen as we go through the slides for the presenters. So during the presentations, please feel free to enter any questions that you have in the Q&A box on the bottom right of the screen. If you should have any technical difficulties, please try exiting the session and logging back in. You can also send a message in the Q&A box, and you will get technical assistance. So to start, what's the challenge? So the costs of ill health can be enormous to both individuals and to society. This includes both direct healthcare costs as well as indirect costs related to reduced labor productivity or lost income. Achieving the SDG health targets would require new investments increasing over time from an initial $134 billion annually to $371 billion by 2030. Chronic disease, much of which is preventable, will make up 57% of the global health burden by 2020. In the United States, health spending was over $10,000 per person in 2016, and absenteeism cost employers $226 billion per year. So over the last couple of decades, we've seen a variety of innovative ways that have been developed and used to either increase the volume of funding for health or to make spending more effective. Some of these include sin taxes, the solidarity levy on airline tickets, and IFM, the International Financing Facility for Immunization. In addition, the idea of paying for results in health has grown over the last decade. For example, the Health Results Innovation Trust Fund at the World Bank. Social and Development Impact Bonds, or SIDS and DIBs, focus on paying for results in the health sector. They're a form of results-based financing or payment by results that have emerged in the last several years. So what are impact bonds? Well, to start, they aren't bonds at all. There is no fixed guaranteed return. It's a bit of a misnomer, but it seems to be that we're stuck with that term. In the United States, the term is is Pay for Success Financing, or PFS, which describes what the mechanism does. We usually describe them as a combination of results-based financing, impact investing, and public-private partnerships. So in an impact bond, investors provide upfront capital for a social service, and an outcome funder agrees to pay those investors back based on a set of agreed upon outcomes. The idea is that outcome funders pay for the successful achievement of outcomes and don't pay when those outcomes aren't achieved. This is based on an evaluation or verification of administrative data. So it provides an opportunity for investors to achieve both a social return and a financial return, as usually the outcome funder pays the investor back their principal plus interest. There are two basic categories of impact bonds: social impact bonds, which is the original concept, where the outcome funder is a government entity, which could be a national level ministry, for example, or a state or local government. In a development impact bond, or DIB, the outcome funder is a third party, such as a donor agency like the World Bank, for example, or USAID, or even a foundation. So in addition to the stakeholders already mentioned and that you see on the slide, there's often an intermediary who can play the role of bringing all the stakeholders together, structuring the deal, and sometimes conducting performance management with the service provider. There are often lawyers, an evaluator as well, and sometimes even an additional technical assistance entity. So based on our research so far here at Brookings of the global impact bond market, we've found that impact bonds have the potential to increase collaboration across different actors, to encourage performance management and adaptability. They promote learning through evaluation and create a clear case for investing in what works. On the other hand, so far they have found to be pretty costly in terms of their development and quite time-consuming. And on average, the impact bonds to date are pretty small and bespoke deals. So what does the global impact bond market look like to date? So by the end of this month, there will be 101 impact bonds that have been contracted globally. 96 of those are social impact bonds, or SIBs, and 5 of those are DIBs in developing countries. This spring, the first SIB was contracted in a developing country, one for job training in Colombia. Of the impact bonds that have been contracted to date, the employment sector dominates, and that's followed by social welfare. There are 13 impact bonds that have been contracted in the health sector. In our database, we have around 20 impact bonds that are either in early or late stage design in developing countries. And of those, the majority are in the health sector, followed by employment and then education. Regionally, in the developing world, the majority are in Africa, followed by Asia and South Africa, of those that are in development. So why impact bonds for health? As I mentioned earlier, the burden to both individuals and society of the direct and indirect healthcare costs can be enormous. Impact bonds in health have 3 potential goals. So the first is around preventing illness. So encouraging behavioral change that leads to reduced prevalence of illness, which in turn reduces both direct and indirect costs. The examples later today will explore impact bonds in the prevention space. The second category is a slight twist to that, which has more to do with reducing the indirect costs of illness. So, for example, an impact bond, which we'll be launching later this week, on reintegrating cancer patients back into work. Megan Golden from Mission Cure will discuss today the potential for using impact bonds to find a cure for a disease, which is a new idea. So what do we know about the impact bonds for health that have been contracted so far? So 2017 was a big year for health impact bonds. 7 of the 13 impact bonds that have been contracted were contracted this year. The focus areas on the prevention side are for hypertension, diabetes, and maternal and newborn health. And then in terms of reducing indirect costs of illness, they include, for example, reducing sick leave, work reintegration for cancer patients, as I mentioned, physical rehabilitation, and mental health. There are 11 impact bonds for health in high-income countries, and then the 2 remaining are in low- and middle-income countries. There are 9 impact bonds in design in low- and middle-income countries, and that includes impact bonds for cataracts, for newborn care, for malaria, diabetes, early childhood development health outcomes, HIV prevention, chronic illness, and water, sanitation, and hygiene. So we have three excellent panelists speaking about three different impact bonds for health. We will first have Yaron Neudorfer, who is the CEO of Social Finance Israel, speaking about an impact bond for type 2 diabetes in Israel. We have Priya Sharma, Senior Policy and Innovative Financing Advisor at the Center for Accelerating Innovation and Impact at USAID, who will be speaking about an impact bond for maternal and newborn health in Rajasthan, India. And then Tara Jathwani, National Strategic Innovations Manager at Nurse Family Partnership, speaking about an impact bond for maternal and child health outcomes in the state of South Carolina in the United States. So with that, I will turn it over to you, Yaron. The floor is yours.
Okay, thank you very much for the introduction, and good afternoon from Tel Aviv. I'd like to give you the example of a social impact bond we launched last year on preventing type 2 diabetes. But let me use the first minute of my presentation to talk about type 2 diabetes. I know that all of you know what type 2 diabetes is because there's a lot of news coming out about it. But did you know that type 2 diabetes is the #1 cause of blindness, #1 cause of amputations? If you suffer type 2 diabetes, you have twice the chance to suffer a stroke or 3 times the chance to get a heart attack. So these are bad news. Every 6 seconds in the world of today, there's a new patient with type 2 diabetes. And today, in the world today, there are around 420 million people with type 2 diabetes, growing to 640 by 2040. By the way, it's the same amount, about the same amount or slightly less of pre-diabetics, and we'll talk about it later. 75% of them are suffering from a low income status, low socioeconomic status, and the expenditure, the global expenditure on type 2 diabetes is around 12% of the global healthcare expense. So it's a lot. So these are the bad news. What are the good news? The good news are that type 2 diabetes is preventable, and also preventable in a very, very simple way. And we need to detect it by a simple blood test. There's a lot of research that came out in the last a couple of years on how to prevent type 2 diabetes that we use in order to develop our social impact bond. So if these are the good news, if this is preventable, why it's not being done? Why are countries and healthcare organizations not dealing with the prevention of type 2 diabetes? And there are a couple of reasons. You can see the slide. I'm not going to read you the slides, but just go through some important points. So the first point that I want to stress is that health management organizations, HMOs, usually are very busy with the urgent rather than the important. The healthcare systems are not designed to deal with the most important, but they're usually dealing with the most urgent problems that take almost 100% of their time. The next reason that I want to point out is really that in prevention, you don't see immediate results. You see the results after a couple of years, sometimes many years. And given the structure, the economic structure of these organizations, sometimes it's not in their benefit to do prevention because only the next person after you will realize the savings and you do the expense. The next reason is, of course, the intervention itself. It's complicated. It's not a shot against flu, which is a very simple type of intervention. It's an intervention that deals with a change of lifestyle. And changing lifestyle is maybe, as you all know from your own personal cases, the most difficult thing to do and the most expensive thing to do and the most complicated process to go through. The fifth point that I want to point out is that the healthcare systems and healthcare organizations usually are best at treatment rather than prevention. So if we can go to the next slide. Can you move one slide ahead? Do you hear me? Maybe it's stuck here. Hello?
Yeah.
Can you hear me now?
I hear you, Yaron. Yaron, I hear you. We're on the slide advantages of SIDS.
Okay, yes. We are on the next slide. Why don't healthcare systems, advantages of SIDS. This is the slide that I need.
Great.
Okay.
So
if you can hear me, I will go on.
Yes, we should be on the advantages of SIDS slide.
Okay, that's not what appears on my screen, but I will go on.
Okay.
So why to choose a SIB to deal with diabetes? First of all, it enables the healthcare organizations to deal with the important rather than the urgent, and to prioritize those members of these organizations that need the important treatment of prevention. Secondly, of course, as Emily described earlier, the mechanism of how a social impact bond works, it enables them to shift the risk from the organization themselves to the investors, and to match the time of the income to the time of the expense. So they bear the savings at a later stage of the prevention, and this is when they pay for successful results. The third point that I want to highlight is really the ability to pool resource. Usually, diabetes is a multi-system disease. Since it's a multi-system disease, usually there is more than one organization or one agency that bears economic savings in the case of prevention of diabetes, or economic benefits in the case of prevention. So if we can pool resources and bring in more than one outcome payer to pay for successful outcomes, this is definitely an advantage for all participants in the outcome payment side. And the fourth point that I want to highlight on the right side of the slide is really the point about performance management, because using a social impact bond with performance management really drives innovation. Since I have not much time left, let's skip the next slide, and move to the slide of let's say tackling type 2 diabetes. So what are we going to do? We're going to deal with 2,250 pre-diabetics. Pre-diabetics are those where you can really still prevent the onset of diabetes or them shifting to become diabetic patients. And we're going to give them 1 year of intensive intervention in changing their lifestyle around 5 different concepts. The first one is nutrition, physical activity, use of technology, a lot of work on motivation, and do workshops for those who are going to drop off the program. And then we're going to measure what happens to them compared to a control group over 5 years. We estimate that after the 5th year, we will be able to see a reduction between the intervention group and the control group of 50%. And if we see 50% reduction in the onset of type 2 diabetes, or the turning from a pre-diabetic to diabetic patient, this realizes a lot of savings. And here is one part of the innovation is that it's not only the healthcare management organizations that will pay for the savings, but also the National Insurance Institute, which is somewhat like your Social Security in the US, that will pay for their part in realizing savings on reducing disabled allowances that they pay for those who become disabled as a result of diabetes. I want to jump to the last slide. Sorry? Okay, I want to jump to my last slide, and I'll try to be very, very quick and tell you about what is the innovation in this whole type 2 diabetes SIB. First of all, is really the ability to pool resources between 3 different outcome pairs, 2 HMOs and one national insurance institute. The second one is that all outcome payers agreed on the same measurement and research protocol, which is very complicated in the case of healthcare. The third point that I want to highlight is that is the ability to scale, not only to scale within Israel from over 2,000 patients to a national level. And in the contract we signed with the government, with the outcome payers, actually, they put a lot of clauses that enable them to learn what happens here in order to be able to scale on a national level. But this is one degree of scaling. The other degree of scaling is, of course, the global scaling. And I can tell you that we work with quite some other countries that are interested in adopting this model. And the last point that I want to touch on is really a very interesting innovation that we did on the referral process, where we developed a scoring system together with one of the HMOs that basically evaluates which of the candidates is going really to be ill with type 2 diabetes in the next couple of years, and they will be the first priority. Last point that I want to touch in is, because I guess there will be questions about it, who are the investors? The investors are 50% Israelis, 50% international investors that are coming from different variety of considerations, but most of them are interested in really the ability to succeed with the lifestyle intervention to change the course of a disease. So this concludes my presentation, and thank you very much for listening.
Thank you so much, Yaron. That was fantastic. Really nice to hear also a little bit more about type 2 diabetes and understand what an enormous challenge that it is. Before I hand over to Priya Sharma, I just want to remind everybody, if you have any questions, please type them into your Q&A box in the bottom right-hand corner of your screen. So now I'm going to hand it over to Priya Sharma from USAID. Take it away.
Great. Thank you, Emily. Just want to make sure everybody can hear me.
Yes, we hear you great.
Okay, great. And if you can move to the first slide titled Overview of the Opportunity, I'll just start from there.
Perfect, we're there.
Okay, great. So thanks, Emily, for the opportunity to present. We're very excited about this development impact bond that we launched almost 2 weeks ago, actually in India. So it was launched by our administrator, Mark Green, while he was there for the Global Entrepreneur Summit. So it's very exciting for us. It's the first one in health for USAID and the largest so far. So we're very excited about this opportunity and to be able to share it with you all today. So India has some of the highest maternal and newborn mortality rates, and the state of Rajasthan in particular has some of the highest in India. And so that has obviously been an area of great concern and work for the government of Rajasthan. So they've done a lot of work to try and improve those indicators, and specifically focused on getting women to deliver in facilities with the hope that that would actually start to make a dent in some of the high maternal and neonatal mortality rates that we're seeing in India. But unfortunately, while they have been successful in being able to incentivize and encourage women to deliver in facilities, the rate of maternal and neonatal mortality had not dropped by as much as they had hoped. And so additional ongoing research had identified that much of this could have been due to the quality of care that women and newborns are receiving when they're actually in the facilities. And so this particular development impact bond focuses on improving the quality of care in private facilities in Rajasthan. So next slide, please. So with that in mind, I think a little bit more context would be helpful. So there are quality standards that public facilities have to adhere to, specifically around different types of interventions, including labor and delivery. But private facilities do not necessarily have to adhere to those standards. And so that's part of the issue driving some of the poor quality of care that we see in facilities, but then also some of the poor outcomes as a result. So what this development impact bond is going to try and do is work with private facilities in the state of Rajasthan, and we've targeted about 400 to 450 facilities that we'd like to do as sort of our base case target, and work with these facilities to get them to a level of kind of appropriate accreditation. So we're using government standards that have been implemented or are being implemented currently in public facilities, and working with these individual private sector facilities to help them meet those very basic sort of levels of quality standards. So this includes ensuring that that facilities have the appropriate drugs and commodities that they need, to be able to have a safe delivery, that facilities have the ability to carry out an emergency C-section should a woman need help during delivery, that they have a CPAP machine or something that can help, or a resuscitator that can help in the event that a baby is not breathing after birth. Basically, all of the things that you would assume or like to see in a facility to ensure the most successful outcome when a woman walks in labor and a baby is born. And so the outcome that USAID and Merck for Mothers will be paying out on is the achievement of those accreditation standards. And if we move maybe quickly to the slide that has the actual, we'll skip 2 slides and go to the slide that actually has the structure of the DIB, and I can walk through more that way. So in this particular case, UBS Optimist Foundation will be the upfront investor. Palladium is our intermediary and our kind of project manager, and we have 2 implementing partners, PSI and HLS PPT, who will be working with private facilities in the state of Rajasthan to help them achieve those accreditation standards. And there are 2 levels at which outcomes payments will be paid out on. So there's the achievement of sort of kind of halfway mark where we're seeing progress, but they haven't fully achieved the full level of accreditation that we'd like to see, and then full accreditation. And that was structured in this particular way because outcomes will be paid out every 6 months. So it could be that a facility has achieved, half of the standards that we would like to see, or they're sort of halfway there, and we would like to reward that level of success, because some of the facilities that we will be working in will have, we'll be starting from a very, very low baseline of quality of care, and we recognize that is a difficult situation to be starting in, and so we do want to reward that level of effort. So results will be paid out every 6 months. The DIB will go on for about 3 years, and we've hired an independent verifier, which in this case will be Mathematica, to help verify those results for us. And then on the back end, as I mentioned earlier, USAID and Merck for Mothers will be the ones paying out for those results, which again, in this case, is the achievement of accreditation by each of these private facilities. So that's a little bit about the structure. As I mentioned, this is the first one in maternal and newborn health. What is exciting about this is that it dovetails very nicely with existing work that the government of Rajasthan has already prioritized and identifies a gap in some of the work that they are doing. And so hopefully in this way, we are sort of working together as part of a larger partnership with the government of India to be able to address kind of a very critical and pressing issue. So next slide, please, Emily. And that for us is very important. So as a development agency, we're always looking for ways to be catalytic and sustainable in the work that we're doing. So not only is this development impact bond part of a larger sort of initiative and effort that the government of Rajasthan is running, but they themselves are committed to potentially taking this on at the end of the project. So they have signed an MOU that basically states that, should proof of concept have been demonstrated and should success be demonstrated at the end of this particular 3-year impact bond, they will be taking this on as the outcomes funder. So I think this is a very exciting example of how a development impact bond will transition into a social impact bond. And in that way, not only has USAID been able to be catalytic in our investment, but we're also thinking about long-term sustainability and ensuring the continuity of the intervention over time. So it's not just a 3-year intervention where care is improved for the course of those 3 years, but we're also looking to beyond. And additionally, as I mentioned at the start of this, private facilities aren't required to be accredited. But what we're hoping is that with government support and with demonstration of impact, that will change. So what we are hoping to see and hoping to continue to work with the government and other key stakeholders in Rajasthan and maybe in India is to encourage and incentivize a change in some of that policy. So, if we can demonstrate that results are improved by improving the quality of care in private facilities, then linking reimbursement on behalf of national or private insurance to the accreditation will be a critical way of ensuring that private facilities maintain that accreditation, but also are incentivized to continue to work to improve quality beyond the life of the project. So the 3-year development impact bond has the ability to impact up to 600,000 pregnant women and save up to 10,000 women and newborn lives. So I realize there's a typo in there. I apologize. So we're, as I said, very excited about this. USAID and Mark for Mothers have committed up to $8 million to make available for outcomes funds. Should PSI and HLF PPT achieve the results that we hope they do. And maybe I'll stop there and take questions later.
Great, thank you so much, Priya. Congratulations again, and I think that the aspect of the shift from the DIB to the SIB is a really important one, as well as the size of this impact bond. So we're starting to see a bit of a shift in the impact bond market with some increased in size impact bonds. All right, so next we have Tara Jaswani from Nurse Family Partnerships, who will talk about the impact bond in South Carolina, focusing on maternal and child health outcomes. Take it away, Tara.
Okay, thank you, Emily. Hello, everyone. Do you hear an echo? I'm sorry.
Oh, I hear you just fine.
Okay, great. Next slide. Okay, thank you, Emily. Let me start by setting the context of the South Carolina Social Impact Bond, or what we call the Pay for Success project, by briefly explaining who NFP is and what we do. So we're an evidence-based home visiting health program that helps transform the lives of low-income, first-time moms and their children. This Nurse Family Partnership was founded by Dr. David Olds, and we have 4 decades of research showing the favorable impact of the program on pregnancy outcomes, on child health and development, and economic self-sufficiency of the family. So the goal of the program is looking at prevention, intervention, and a comprehensive approach to looking at health outcomes. The health of the mom is the health of the baby, is the health of the community, and the health of a society. And with 40 years of research, we are now positioned in a place to really look at multi-generational effects of the family. The way we do this is by using the model, the expert, specially trained nurses, compelling evidence-based data, and also looking at a specific time period of the role from pregnancy through child's age 2, because we know that these first 1,000 days are extremely important when we think about child development and early intervention. So the relationship between the nurses and the moms is absolutely key to this program, because that's what yields the cost-saving outcomes to government and society. Next slide, please. What we have here is a very quick snapshot of Nurse Family Partnership in terms of service. So what we're looking at is, since the replication of the program began in 1996, we have close to 270,000 families served, over 33,000 families currently enrolled, and the number of states that we serve is 42 plus, U.S. Virgin Islands and 6 tribal communities. The reason we wanted to show this is because although we have these numbers, we know it's not enough. There are many more vulnerable moms and kids out there who we need to reach and we need to serve. And that's why innovative approaches to financing to reach and service these populations are so critical for us. Next slide, please. South Carolina is an example of where that need is great because we have such a high number of children living in poverty. So NFP launched in South Carolina in 2009, where we were serving around 600 families at the time. By 2015, we were at around 1,200 families. But again, it wasn't enough, and it's not enough. So after much planning, the South Carolina and Nurse Family Partnership launched the nation's first Pay for Success project to improve maternal and child health outcomes. We piloted in January of 2016. We launched in April of 2016. And the project extends those NFP services statewide to an additional 3,200 Medicaid-eligible first-time moms and their children. The project is over a 6-year period with a 7th year for evaluation. And it spans 29 of South Carolina's 46 counties, and we have 9 implementing agencies that are providing these services to our moms. What's really unique about this project is that it leverages both private and public funding.
We have philanthropic investment at $17 million, coupled with Medicaid reimbursement through a 1915B waiver at $13 million. And this coupling of funding is important because it leverages payment and sustainability. So, for example, funders have agreed to reinvest 100% of success payments back into nurse-family partnership beyond the life of this project. And secondly, the Medicaid piece served as a predictable and sustainable funding stream for South Carolina. And of course, all of this is predicated on whether the results are positive in terms of the evaluation. Next slide, please. The project is a true collaboration and continues to be till today, as we're into 2 years. We have strong committed partners, and that is part of the critical nature of the success of the project. So from our service providers in South Carolina to our philanthropic investors, to, of course, our outcome payers, to our intermediary, social finance, who supported the financial structuring of the project and coordinates performance management, and all the way through to technical assistance and through our evaluator for JPAL North America. Again, that collaboration is really key and continues to be key. Next slide, please. Here's a quick snapshot of the project. Methodology, randomized control trial. This is a rigorous method, as we know, with treatment and control groups that are designed to evaluate the efficacy of the program in its scientific, purest sense. Our outcome metrics are also critical to the project. Reduction in preterm births and child injuries from hospitalizations and emergency room visits, increase in healthy birth spacing, and first-time moms served in low-income zip codes. Now, these outcomes are amenable to a PFS project because they are measurable through administrative data or through collected data, and they can be collected during the time period of the project itself. That's very important. And that's also important because it's critical for the evaluation piece, where the level of outcomes achieved inform our outcome payments. Now, in spring of 2020, we're going to be announcing our first evaluation results from the preterm and low-income zip code outcome metrics. And in spring of 2021, we'll be announcing the evaluation related to child injuries and healthy birth spacing. Next slide, please. This project was constructed with numerous innovations to test as part of the deal. From the increase in nursing caseloads through gathering certain efficiencies to the implementation of telehealth as a strategy to complement nurse in-home visits, robust marketing and outreach campaigns, as well as leading to a reduction in program costs, scaling up and maintaining and model fidelity of nurse-family partnership. Now, this is a really critical piece because we really needed to mesh our business parameters without impacting the fidelity of the model, and that's a tough thing to do in situations like this, but it's certainly something that we are committed to. Next slide. Now, we wanted to be very transparent and specific about our key learnings in almost 2 years of the project. So in terms of our successes, we know that in enrolling our moms into the program, it's been a tough undertaking. It's been a lot of learning. And it's also something that we don't always have control over. For example, natural disasters such as Hurricane Matthew really impacted enrollment initially during the project. But as of November, our enrollment was ahead of projections, which is pretty unusual for an RCT type of study at this point. We also saw some successes in terms of nurse education, specifically around randomized controlled trials, which require a different process of learning for nurses. Now, of course, we've had challenges, or what we like to call opportunities, and I want to focus on one main challenge, and that is locating young moms and moms in low-income zip codes. We wanted to locate these highest risk moms, the ones we want to ensure benefit from this type of program and this type of project, but they're also the hardest to reach. So we know our projects don't happen in a vacuum. They happen in the context of social and demographic changes. So for example, in the case of locating our young moms, In the past 10 years, South Carolina has seen a significant decrease in the number of teen pregnancies. And this is through robust initiatives and campaigns by the state. And this is a good thing. So we're happy to see this decrease. However, it presents a challenge for us to really reach these highest risk moms. And similarly with low-income zip codes, we have all of that information. So despite the challenges and our goals and dedication to the project remain the same, and we really look forward to continuing this project and seeing where it really lands us. Thank you for your time.
Great. Thank you so much, Tara. It's really interesting to hear more about the NFP model. And also thank you so much for sharing the challenges. I think it's really important for all of those who are interested in exploring this tool to recognize that there are great opportunities, but there are also challenges. So thank you for being open about that. So now we'll jump into a question and answer session. We have a lot of questions. In interest of time, I will take a few of them, and then we will attempt to compile those and put it up online together with the webinar, which is being recorded, and the presentation. So I'll give you each one question. Question for Yaron. The question is, what results have been shown so far with the SIB? Do you have any results to share thus far? And if not, maybe you could share a little bit about the challenges that you faced or any particular successes.
Okay, thank you for the question. We just started the referral process of the first cohort, the 3 cohorts, 450, 900, and 900. Every year we start a new cohort over 3 years. We started the first cohort just 3 or 4 months ago. We do see initial results of people losing a lot of weight, a lot of kilograms. Even some people did lose a double-digit number already, which will make an effect over long years. We don't have any official results yet, and I think that referring to the challenges, the biggest challenge that we face until now is really the referral process. You know, as I said during the presentation, lifestyle intervention is extremely complicated, and we all know from our own experience that you start the process and then just stop it or desert it in the middle, and dealing with the people and preventing them from dropping off the program is really, I think, the biggest challenge. The way we deal with it is a lot of work, more work on the psychological and motivational parts, even rather than losing weight and getting into some physical activity, because this is the real driver. We developed a very interesting system around it. If I had a couple of more minutes, I could elaborate, but I think I'm stopping.
Great, thanks, Yaron. That's great. I like the background music of the ambulance, which is quite apropos given that this is a webinar about impact bonds for health. So a question to Priya. Actually, there were several questions around the outcome metrics. The main question is around the accreditation versus the reduction of maternal and infant mortality. Can you speak a little bit about your selection of the outcomes? And then another follow-on question to that is, how will Mathematica be verifying the achievement of outcomes? If you could talk a little bit about that. Thanks,
okay, thanks, Emily. Yeah, and I will preface my answer by saying I wasn't involved in kind of that discussion around the selection of that specific indicator, but I was party to conversations before then. And I think one of the challenges that we face is really being able to attribute the specific intervention that we are implementing to a specific outcome or output. I mean, there was a lot of discussion around outcomes versus output, and we really tried to look for an outcome measure, but we don't work in isolation. So in many of the countries and regions that we do operate in, we are one of many donors or one of many programs that are being implemented. And so, being able to link our specific intervention to a decrease in maternal or neonatal mortality over a specific time period, we felt was going to be really difficult, especially as we were trying to think about, demonstrating the success of impact bonds as a way of working in the development space. And so we made a little bit of a compromise in the selection of an indicator that is maybe more output-based and outcomes-based, so the achievement of accreditation standards. But there are kind of well-known, there are sort of well-known links and well-documented links and studies that do demonstrate that, the improvement of quality of care can lead to specific reductions in maternal and neonatal mortality. Also important to know that in many of the countries that USAID operates in, labor and delivery and that period of time is actually is kind of that period when the majority or many cases of maternal and neonatal deaths occur. So there is a very strong theory of change, but yes, there is some modeling that was done to estimate those outcome numbers, around 600,000 women and newborns impacted, and then 10,000 up to 10,000 lives saved.
Great, thanks, Priya. We're going to go on to a question for Tara, just in interest of time, and in the follow-up we can come back to the further questions about the evaluation, et cetera. So Tara, here I think this is a really interesting question. How is the experience of managing the 9 NFP implementing agencies? Are there variations in agency performance? How are variances in interagency performance managed, and how does that impact the overall performance of the Pay for Success transaction?
Sure. There are certainly variations, and that's something that we've had to watch very closely and collaborate with our agencies in over this time period. I think one of the one of the key things in terms of doing that is actually building that relationship with the agencies and checking in constantly. So we make sure that there is data flowing back and forth in terms of how each agency is doing, where there are certain areas where agencies can be improving. And that communication piece has been absolutely critical to how we work with these agencies and how we really look to improve processes along those lines. And I will say very quickly, the one thing we have certainly learned from an internal standpoint as an organization is that we've had to change the way that we work based on this project. We've had to look at data collection processes differently. We've had to really work, try to integrate those processes with our agencies so that we can monitor these differences or changes that we want to see happen within the agencies. But again, it's been highly collaborative, and yes, there are variations, but we really try to just keep on top of it through constant communication and process building.
Great. Thanks so much, Tara. All right, we are now going to shift to the second part of this webinar. I'd like to introduce Megan Golden. She's the co-founder of Mission Cure. She also has a lot of experience in the Pay for Success space, having been very engaged, particularly in the early child development space in the U.S., through which we had the opportunity to get to know each other. So Megan, I'm going to hand it over to you.
Great, thank you, Emily. And I'm very happy to be here and especially excited to hear about the Nurse Family Partnership project in South Carolina, because I had the privilege of being involved at the feasibility stage in that project, and it's good to see it on the ground actually helping at-risk moms. So as Emily mentioned, I was leading the Pay for Success financing work at the Institute for Child Success, and that we were providing technical assistance going around the U.S., helping jurisdictions that were interested in applying impact bonds or Pay for Success financing to expand their early childhood programs, when my younger brother, Eric, got sick. He was diagnosed with a digestive disease that is extremely painful, progressive, and that puts him at high risk for pancreatic cancer. And it's a disease for which there is no effective treatment to change the course of the disease once you get it, and no cure. So next slide, please. I started looking into with him why there was no effective treatment for his disease, and the reasons sounded pretty familiar, and I'm sure a lot of the participants here will think so as well. One is that there's not enough resources to take the promising interventions, prove them out, and bring them to scale. And in this field, there's the term the valley of death, which means that while there's some public funding for basic research, there's virtually no funding to get the promising things to commercialization, especially for diseases that don't affect a huge number of people or aren't attractive investments. Second, the incentives for funding, when it exists, are based on the profit that will come to the investors and the pharmaceutical companies, and not necessarily patient outcomes. Third, the stakeholders are not all working together to achieve specific outcomes as they do in these impact bond situations, but they're competing for grants and publications and funding. And then finally, there's a real mismatch in the timeframes between what patients and their families need and the traditional scientific and funding process, which could take quite a long time. So I started thinking, impact bonds, outcome-based financing were designed to address exactly these problems. So could it be applied to cure a disease? And so next slide, I started talking to the people that I knew from this impact investing, impact bonds, pay for success field, as well as experts in the kind of scientific community, and got enough enthusiastic feedback that I actually left my job at the Institute for Child Success, and we launched Mission Cure to pioneer a new model to cure disease. So next slide. So except for the cost-effective methods to cure disease on the bottom right of this slide, this approach is really the same as the one that you've heard about from the other presenters who are implementing impact bonds for health. Financing based on patient outcomes, partnerships with impact investors, active collaboration among stakeholders to achieve those outcomes, and then the intervention is these cost-effective methods to cure disease. So next slide. Our first target, you won't be surprised, is the disease that my brother is suffering from, called pancreatitis or chronic pancreatitis. And we're using this as our proof of concept, but really this financing could be applied to multiple diseases, and that is our goal. So just some background on what chronic pancreatitis is. It's chronic inflammation of the pancreas, which is the organ that produces digestive enzymes and insulin. And that leads to scarring and destruction of those functions. But the primary symptom is excruciating pain. This disease affects 150,000 people approximately in the US, including about 10,000 children, and well over 1 million globally, and it's increasing. And it's just, it's a devastating disease. And if you go to the next slide, I'm just going to give you a flavor of how desperate the patients are. This is a letter from the leader of an online support group for people with chronic pancreatitis. She says about 2,000 members, and talks about how emergency rooms are treating them as drug seekers and humiliating them. Many have attempted suicide because they can't take the pain any longer. And then at the end, she makes a comment that I've heard from multiple people, which is, many of us are willing to volunteer as test subjects, if not to help us, to help future patients and the kids who get this horrible disease. So people are desperate, but they're willing to participate in research, even if it's not going to help them. So next slide. And a lot of people with this disease become so debilitated that they're unable to work or to go to school. And if you go to the next slide, this obviously has a big impact on them and their families and their employers and communities, but there's also a big financial cost to our healthcare systems. It's really a disease that we're spending a lot, our healthcare system is spending a lot of money on. There's about 56,000 hospitalizations per year in the US, and one rigorous data analysis of from a federally funded study of children with pancreatitis showed an average cost of over $40,000 per year per person, and that was actually on the low end for the people who did not get surgical interventions. But if you multiply that out for the 150,000 patients, that's over $6 billion per year. And so we're paying all this money, and the outcomes are terrible. So what if we could get some of the entities that are paying all this money for this disease to put some money toward incentivizing improvements in patient outcomes, which may also save them some money? So here's how the financing will work. We get outcome payers to agree to pay for improvements in specific patient outcomes over 10 years. And the outcomes could be healthcare payers. We're talking to a couple ones of those in the US, Medicaid or the National Health Service in the UK, or potentially philanthropists who could do a kind of outcome-based philanthropy. And then with that promise to pay, we would raise money from impact investors who will be able to get a return based on improvements in patient outcomes from those outcome payers, but also potentially from the market, from commercialization of investments. And then Mission Cure will take the funding raised and invest it in a portfolio of strategies that are designed to achieve the improvements in patient outcomes. And we'll kind of work with the group of stakeholders to manage to improve those outcomes. And then in 10 years, and I'm just using that as a hypothetical, you'll see improvements in patients through new therapies and better practices, and impact investors can receive a return. So just the next slide will show you some possible patient outcomes to determine payment, which we've vetted and are still working on refining, but most of these seem feasible. If you go on to the next slide, they are decreased emergency room visits and days in the hospital, decrease in days absent from work or school, decrease in pain. There's actually several validated instruments to measure pain. And then the fourth one is survival or disease progression. So next slide. Mine did not advance, Emily, but it should be on strategies to develop effective treatments.
I'm seeing that. It might just take a second to load up.
Okay, that's fine. I will go ahead. So the idea is that we will invest in a portfolio of strategies to achieve the outcomes. And instead of going through these, I'll just give you an example. So scientists in India, where chronic pancreatitis is an even bigger problem than in the US and growing, just published a study of the drug that's in the over-the-counter medicine Prilosec, which is also available in generic. And it tested that drug in a small randomized trial of people with chronic pancreatitis, about 130, 140 people, and found that it gave 97% of them relief from pain in 2 weeks at a high dose. And that relief from pain continued for a year and did not have side effects. So more research needs to be done for this to become an approved treatment that doctors, that would be approved by the FDA, or that doctors would feel comfortable prescribing in the US. But we don't need a $1 billion drug development process for that to happen. Researchers in the US could conduct a trial for about $250,000. And the nonprofit Cures Within Reach, which is our fiscal sponsor, is very experienced at doing those type of drug repurposing trials. And if that works, it could bring relief for these thousands and thousands of adults and children who are suffering from the horrible pain. So this is one example, but we have more than 30 already approved drugs where we've identified concrete steps that could be taken that are not too expensive that really could impact patient outcomes. So next slide. It seems like impact investors are interested in investing in health and disease cures. But the question is it realistic that these investments could produce a return? So next slide, there's actually a growing number of examples of similar types of investments. The Cystic Fibrosis Foundation is the big example in the field. They invested in about $100 million in something called rapid throughput processing to identify effective therapies for cystic fibrosis. They found a treatment that's essentially a cure for a small portion of the people affected, and then sold the rights to that treatment for $3.3 billion. Now, while I think that some lessons were learned from that experience, and I don't think that exact experience will be replicated, that foundation has really used investments alongside grants to make incredible progress for people with cystic fibrosis, increasing the life expectancy from under 10 years in the 60s to 37 now and increasing. The Juvenile Diabetes Research Foundation is using a similar venture philanthropy approach. And Solid Biosciences is a for-profit life sciences company dedicated to solving one disease, Duchenne muscular dystrophy. And it has investments from commercial investors who believe that they'll receive a market return on their investments. Next slide. So this could be a win for all of the stakeholders involved, and I won't go through each one. And really, I think that it could be the beginning of a new approach to curing disease, where resources are shifted from ineffective treatments and emergency response to incentivizing real improvements in health outcomes for the people who are affected. And next slide are partners. So we have seed funding from the National Pancreas Foundation and fiscal sponsorship, as I mentioned, from Cures Within Reach. And then we're also working with the National Institutes of Health, the American Pancreatic Association, and as well as some international pancreas experts. And finally, we invite your input and your partnership as we move forward. Thank you.
Great, thanks so much, Megan. This is a super exciting, I think really on the edge idea, and I really appreciate you sharing this in its early stages with us and our audience. So we now have the opportunity for a response to the presentations from John Simon, who, as I mentioned, is the vice chair of the board of the Global Fund to Fight AIDS, Tuberculosis, and Malaria, as well as the founder and managing partner of Total Impact Capital. I should have mentioned this earlier, the bios of all of our presenters are available in the link that was sent to you when you signed up for the webinar. John, in addition to this, has a long career, including been at OPIC and USAID, and having worked in the innovative health financing space for some time. So the floor is yours, John, to share with us some of your comments and responses to the presentations that you heard today.
Thank you, Emily, and thank you to all the presenters. These are obviously incredibly exciting projects, each one of them. I think it's worth noting sort of the innovations that are being presented and the opportunities they create. I mean, I think with regard to the diabetes social impact bond, the opportunity to get all the multiple players united around one set of common metrics and decrease the fragmentation in the treatment of a very complex chronic disease has tremendous potential to increase the effectiveness of the dollars spent. I think when it comes to the Rajasthan health SIB that Priya went through, the fact that they've gotten the government to agree to scale this up once the pilot is completed addresses a major issue that I'll talk about in a little moments with, I think, development impact bonds and social impact bonds, which is often you put a lot of energy into one specific pilot, but then the question is, how does that move the needle from the point of view of systematic change and impact? And if part of the result is that you get the government bought on to institutionalizing the innovation that's being financed through the impact bond, that in essence answers that major issue. I think along the same lines in the South Carolina example, leveraging the philanthropic dollars with the vast resources that are available through the government's Medicaid program creates again that potential to institutionalize the innovation and create a long-term, sustainable and scalable impact. And of course, the idea of utilizing these types of financing technologies to solve something as impactful as finding a cure for currently untreatable diseases, that has tremendous potential, and something that I think at the outset of the creation of social impact bonds was something that certainly people were imagining could be part of the way that these types of technologies can be deployed. That being said, I think one of the challenges, and Emily, you referenced at the early stages, is that a lot of the promise of social impact bonds have yet to be realized. I mean, you noted that there are 101 that are in some form of execution at this point. But for people who imagined what this type of financing technology could create when the first social impact bond were created, now I think we're going on 10 years. Certainly that's a relatively underwhelming number, and especially if you add up the total amount of capital that's been mobilized, that's even as you noted, Emily, in your opening, even more underwhelming still. And I think one of the challenges that we have is we're too often utilizing this tool for what you would think of as financing new innovation rather than scaling up proven innovation. And so there definitely is a role for impact bonds, and I think the last case is a classic example for impact bonds helping to explore the unknown, helping to mobilize capital when the answer is still not there, and trying to create an incentive, sort of like an X Prize, if you will, to find that answer and get something that ultimately can lead to the result. And the cystic fibrosis example is, an extraordinarily powerful one. That's a foundation that used their own capital to create a billion-dollar innovation. But of course, most efforts at that end of the spectrum of investing are not going to succeed. The classic venture model is you invest in 10 investments, and one of them is your home run, and the rest barely make it or don't make it at all. And that type of record for the social impact bond space is not going to lead to mobilizing the amount of capital that I think we all imagine and imagine that there needs to be. And I think part of the challenge that we've had is we've tried to put all of the pieces together into a single transaction and weigh that transaction down with all the weight of not only identifying the right metric, not only identifying the right implementer, but creating a financing structure that mobilizes an investor, and then of course recognizing that when we don't have a proven model to scale up, we're going to have very thin investors. So then we have to create credit enhancement on top of that, which takes away a little bit of the incentive, the risk incentive that was inherent in the model to begin with. And so I think there needs to be a little bit of a taking the air out of the tires in some of this case, and looking at examples where we can create the model step by step, starting with how do we find the right metric, how do we then incentivize implementers on the ground to perform, how do we create a track record of pay for performance resulting in a better outcome than the traditional input-based performance? And then how do we create a financing vehicle that helps scale that up? And I think there's a whole sort of world out there for growth impact bonds that can be created in this step-by-step process. And then on the other side, there's still a role there for the venture impact bonds, and we shouldn't ignore that role. But we need to not put all of our efforts and resources into that side of the equation, because frankly, that's not where most of the money is. Most of the investment capital out there is looking for investments that have the potential to scale, that are about growth, that are not at the bleeding edge, if you will, of the innovation spectrum. And so, just to sort of end on an optimistic note, I think there's been a lot of work going on in terms of how you can deconstruct this technology and build piece by piece the pieces that are necessary to create a financial product that would be attractive, not just to the foundation investors who are financing, I think, most of the innovations that were identified today, but to mainstream institutional investors who would see this not as a one-off, unique investment that that won't necessarily be replicated, but as a regular investment class that can be invested on at scale and mobilize not just single-digit millions of capital, but hundreds of millions and billions. And of course, if we can't mobilize that amount of capital, all the outcomes we're trying to achieve but with these innovations are going to be left by the wayside. So that's really where I think the opportunity is to find how do we create not just venture SIBs, but more scalable growth SIBs and DIBs. Thank you.
Great. Thanks so much, John, for your insightful comments. I'm actually going to give each of the presenters just 1 minute to respond quickly to John's comments, and then we'll go to some of the questions from the webinar audience. So starting with Priya, do you have any comments or response to John's comments?
Thank you, and thanks. Great, thanks, John, and thanks, Emily. I think, John, the one point that you made around the Rajasthan DIB, where we're thinking about long-term scale and sustainability, that certainly was critical for us, and I think that was something that all of the partners were very clear on right from the beginning. That this is a relatively new way of working, I think, for all of the partners that were brought to the table, but one that I think we're all interested in committing to and seeing work. And success for us is not just impact across the 3 years that the actual intervention will be going on for, but beyond. And getting that government buy-in for us was really critical, and making sure that they're able and willing to take that on beyond the 3-year pilot is really important. And so for us, success also is being successful within that 3 years, but then creating something that can have impact long beyond the 3 years that all of us are engaged. So fully agree that that's maybe been a limitation to date, but something that we're hoping we can at least start to try and overcome with this development impact bond.
Great, thanks, Priya. Megan, do you have any comments?
Oh, sorry. No, thank you, John, for the comment and the context. And I guess 2 reactions. One is that I do think that we're going to see a little bit of generational change in the desire of the investors, or at least potentially, because the millennial investors at least are making noise now that they do want to do things that are really looking at problems and addressing them a new way, rather than being kind of an additional investment class. But I guess that remains to be seen how that plays out. I'll leave it at that.
Great, thanks, Megan. Tara?
Sure, thank you. Thanks, John. I think that just in terms of the PFS work being a new space for us in terms of a nurse-family partnership, I think it was really imperative for us to have the foundational model of what we could base this type of new project on. I think that really facilitated a better understanding for us in terms of here's the evidence, this is what we need to, this is a jump off point in terms of going into this new pay for success space, because it is very complicated. I mean, it can be complicated, and certainly it's something where there are numerous learnings that are happening every day. So I think I think your point was a good one, because having that type of model really does, as I said, facilitate going into this space. Thank you.
Great. Thanks so much, Tara. And Yaron, last but not least.
Yes, so I want to relate to three quick points, John. First is about, actually first and second are the same point. The type 2 diabetes SIB is really the first SIB that is going to mainstream. It's not a niche population. It's mainstream because, as I described earlier, type 2 diabetes is everywhere and with almost everyone. And this is important for us at Social Finance Israel to try and develop models that can be replicated not only inside Israel as a relatively small market, but replicated worldwide and bring something innovative to the world. And we have two different approaches. One is I would define more of the US approach that is really trying to scale up proven interventions, and health family partnership, I think, is a great example to it, versus our approach that is very much planted within the Israeli culture. And this is to try and bring more innovation into the models that we test, and it reflects also on the investors. That's my comment.
Great, thanks, Yaron. I wanted to also speak to that point. I'll take my prerogative as moderator here to respond to that point. So, the majority of the impact bonds so far are looking at scaling proven interventions, but we do see some differences sort of geographically. Indeed, the U.S. has been primarily in the proven interventions space. I wonder if a large or experiment, you're using interventions that really have very little data behind them, is that impact bonds maybe just aren't the right way because they can be very costly. That's something that we talk a lot about, and is a big conversation in the impact bond space. Is sort of is this about proven interventions or sort of experimenting? And our perspective is that, well, what we've seen mostly has been that investors are only willing to sort of take not a huge amount of risk and are willing to invest when there is some evidence around the programs. We do see that some of the programs are being used. Perhaps there's some evidence behind them, but they're being used for a new population or at a larger scale that hasn't been done before. I also wanted to respond to the point around scale in general. One way that is being discussed and we're seeing grow to some extent is the idea of an outcomes fund, and that relates to what you said, John Simon, about really focusing on, what are the metrics that we want to see achieved. So in this outcome fund model, or using what's called a rate card, the outcome funders set out a set of outcomes that they'd like to see and the price that they're willing to pay for them. And that gives an opportunity for potentially multiple service providers to provide those services where, not only it may not be possible for one service provider to achieve that larger scale, and with that, an opportunity for larger investments. There was a question that came in for John, actually, and that was around sort of, do you see commercial investors coming into this outcome-based financing kinds of structures? John, any thoughts on that?
Yeah, well, in my view, if we don't see commercial investors coming into these structures, we have to ask ourselves, what are they really worth the candle? I mean, at the end of the day, the problems that we're trying to address, whether it's diabetes or whether it's mother-child deaths, or whether it's, if we think about it, the perspective from the Global Fund, eliminating malaria, AIDS, or TB. These are problems that require, the Global Fund spends $4 billion a year on a largely traditional grant models. They require, and that's not nearly enough. So they require funding in the realm of the billions, or as we talked about at the Addis Ababa Financing for Development Conference, billions to trillions. And that type of money doesn't exist in the purely philanthropic realm. So the value of putting all this effort and work into creating these models is that you create a mechanism that can mobilize more than just purely philanthropic capital. I mean, from our point of view at Total Impact Capital, when we think about impact investment, we think of it primarily not as an end place, but as a transition point, as a place where innovations and enterprises and new ways of solving the world's problems get initial funding to prove out their worth. But ultimately, if they're going to be successful, their goal should be to attract commercial capital to achieve real scale. I would say to Emily, your point about most of the current SIBs being scale and proven interventions versus experimenting to find new ones. I think that's true in the sense that the interventions have been proven as things have been identified that if implemented effectively, they will have a positive result. I think what you rarely find is a situation where they're scaling a pay for performance model that's already been proven, and the implementer and the payer and the setup that is being financed through the impact bond, that whole piece has already been proven, and you're just scaling that piece up. I think when you look at your impact bonds, while the underlying intervention may have been proven, the way it's put together, the model for implementing it in the case of the SIB is typically new. And in my mind, there's a lot of risk that's created, which inhibits getting that commercial capital when you're talking about a new model of doing business, even if the underlying business is proven.
Yeah, those are good points. I think that the question around sort of I think that we all sort of have a hunch that paying for outcomes should be more likely to get us outcomes than paying for inputs. But in fact, we have very little rigorous evidence around that because that would require delivering two very similar or exact interventions to very similar populations, with the financing and contracting methodology being different to be able to test that. So I think that definitely increased research around kind of getting to the DIB effect is going to be important as we or SIB effect, SIB or DIB effect as we move forward. So there were a couple remaining comments, questions for the panelists. I'll take those really quickly, and then we'll move into closing remarks. So there was a question for Priya, which was about what is the level of risk that investors are really taking on? How do you estimate the likelihood of that target will not be achieved based on what's the evidence or data that's based upon?
That is a very good question, and I'm not sure I can do justice to it.
Yeah.
Yeah, it's a tough one. I can't say that we necessarily quantified it, but certainly I think there is enough of a risk. So working with these types of facilities is not unknown. So both PSI and HLF PPT have experience trying to improve quality of care in both public and private facilities. So to a certain extent, it's not unknown that it's impossible to do it. But I think what is maybe a little bit different is sort of working to specific standards, and then trying to do it within a specific time period at a particular cost. And I think for us, that's the piece that really is around the experimentation. So there's actually risk on all sides, not just the investor, but then also obviously whether PSI and HLF PPT can do it within sort of the cost estimate that we have used to assume that that's how much it could cost to do that type of work, and within the time frame that we've asked them to do it. So unfortunately, I don't have maybe much more of a better answer than that, but I'm happy to mull it over, and maybe Emily, this is something that I can send offline.
Absolutely. No, I think it's a really good question, and it's a tough one. And I think that sort of getting to that, what is the risk and return for the investor, I think is a really key question. And we in fact have another question on that for Megan, which is there concern about paying private investors money that could be spent on patients?
Yeah, that is a good question, and I think as patient groups have gotten more involved in the drug development process, really, with the blessing of the FDA, there's been a lot of work around creating kind of statements of principle as you go into the work. So we will do that, but I think it's less of a concern because right now the patients are not getting anything helpful, so except perhaps opioids. And so there's just such a great unmet need that an investment in things that will end up helping the patients, even if at the same time they produce a return for investors or pharmaceutical companies, would be welcomed with open arms by the patient community.
Great, thanks, Megan. So with that, I would like to thank all of the panelists for sharing their perspectives on impact bonds in health. It's been, I think it's really important to have conversations like these so that the stakeholders who are in early stage design of impact bonds or others who are interested in getting engaged can learn from the challenges and successes of those who have been early implementers. And thanks, Megan, not only for your courage to step out and explore this new idea, but for sharing that with us here today. So stay tuned for more convenings like this from Brookings, both online and in person. If you're interested in learning more, our publications and blog posts are available on our website. And as I mentioned, the recording of today's webinar along with a blog post will be up on our website soon, so that you can share that with others who weren't able to tune in. So thank you again to all of our fantastic webinar participants, and wishing everybody a wonderful day and evening. Thank you.